here at FIU. So this is a pretty special Heart Day because it's our first Heart Day since the center has been fully formed. And in the coming years, you're going to see us grow in cardiovascular research. We're going to have opportunities for high school students, summer high school research program that we run, undergraduate students with an undergraduate research program. We have Ph.D. students, we have junior faculty, we have senior faculty, all involved in the center. It goes across colleges, so we have people from engineering, from biology, from medicine, from nursing, and you're going to see a lot of that reflected throughout the program today. So we're super excited about the opportunity here. So this is our 9th annual Heart Day event. So we started this all the way back, I believe, in 2018 at our first Heart Day event over in the FIU Engineering Center. And I want to take a brief moment to mention that this Heart Day event, the symposium, was started in collaboration with a very special colleague of mine, Dr. Sharon Ramaswamy, who unfortunately passed away this past summer after dealing with a neurodegenerative disorder for the last few years. So he was extremely special to us here at FIU and BME. He is literally the heart and soul of cardiovascular research in our department. He is sorely missed, but we carry this on in his legacy and in his honor. And the presentations today, the poster presentations, and the flash talks in the afternoon, we'll be giving awards that will be named for him now, moving forward in recognition of his support of this event, but also his deep support of the students that are involved in the event. He's an outstanding mentor. So happy to welcome you here today to our symposium. And so just to kind of give you an idea of the schedule, we have a keynote talk this morning, and then we're going to have a demonstration from our STAR Center, which is affiliated with our College of Nursing. That's going to show you how some of these mannequins work that they use to train future nurses and physicians. So that's going to be super exciting. Then we're going to move into an outreach portion where they have some tables set up next door. You'll get to go and even interact with some of these mannequins even more. There's other folks that have tables over there across people involved in cardiovascular research and medicine. And simultaneously, we'll have a poster session going on so you can see what some of our students are doing in research. And so we'll divide folks in half. Some people will go to outreach, some folks will go over here, and then we'll switch halfway through. That'll be followed by lunch in the afternoon. For those who are still around, we'll have flash talks given by, again, some trainees that are in our program. So we'll start with our morning keynote lecture, and super excited today to have a very good friend and colleague, someone I've known for quite a few years, Dr. Goergen, who comes to us from Purdue University, where he serves as a professor and associate head for clinical engagement in the Weldon School of Biomedical Engineering. He's also a fellow of the Biomedical Engineering Society and of the American Heart Association, and he seeks to develop a lot of new imaging techniques to identify, diagnose, understand cardiovascular disease. I think I told Craig a few years ago that he's become the leading expert in this area, and everyone across the nation seeks to collaborate with Dr. Goergen, and you'll probably see it today. He'll throw up slides just casually of some of the top researchers across the United States, of which he is also one. And so my goal someday is to be on one of his slides, and that means I've made it and I've collaborated with him. He started at Purdue a little over a decade ago now, about 15 years ago, I guess, right? And he did his undergraduate training at WashU St. Louis, and then his Ph.D. at Stanford University prior to becoming faculty. So please join me in welcoming Dr. Goergen.
Good morning, everybody. Can you hear me okay? Fantastic. Thank you, Josh, for that wonderful introduction. Thank you for the organizers of this event. It's wonderful to see so many young and inspired young researchers interested in cardiovascular disease. I would love to have a Heart Day at Purdue like you all have here. The fact that there's a center now and real momentum for cardiovascular disease research is super inspiring and something that I think is a testament to Josh's leadership and where FIU and the Department of Biomedical Engineering is headed. Quick show of hand, who's a high school student that didn't know they'd be hearing from me this morning until today? Great to see you all. Thank you for being here. Appreciate it. I will have some technical content here, and I will talk about engineering and mechanics, and there'll be some equations and some mathematics, but I'm also happy to chat and talk to you either after or during the talk. So don't be afraid to raise your hand and stop me at any point. I was told at the beginning of my career that the human attention span on average lasts 7 minutes. So if I drone on for 45, you will all be asleep by the time I end. So feel free to stop me at any point to hear more or ask questions about some of the content. So Real quick, I do have a disclosure. I'm a paid consultant on the scientific advisory board for Fujifilm Visual Sonics. This is a company that's based out of Toronto, and they make high-frequency ultrasound systems. So I'll be talking about those different systems today. I also need for everybody to know that I don't do any of this work anymore. This is the group, and even a few years ago now, but of researchers, postdocs, graduate students, master students, and PhD students, undergraduate students, research scientists that do all this fantastic work. I just get to come up here and talk about it and really emphasize what they've been doing in the lab and all the fun things that they find with our research. So, who's heard of Purdue University? Does anybody know where it's located? Where?
West Lafayette, Indiana.
West Lafayette, Indiana. So, we're all down here in the nice, sunny, warm Florida, Miami here. And in Indiana, I left my house yesterday when the temperature was 23 degrees and there were about 6 inches of snow on the ground. So it is wonderful to be here. But we are about 2 hours south of Chicago, an hour north of Indianapolis. We actually now do have commercial flights in and out of the Lafayette airport. So if you ever want to come visit, you can fly directly to an airport just 10 minutes away from my home. This is the downtown Lafayette area with the Wabash River that separates West Lafayette and Lafayette. Purdue University has a main campus in West Lafayette, another campus in Indianapolis, a network throughout the state. We were just talking about the UF system and similar. We've got locations in Gary, in Fort Wayne, and others. And like FIU, we have a lot of interest in athletics too. So Purdue's known to be a basketball school, not football. IU has now taken that name, but this is Mackey Arena with 14,000 fans cheering on the basketball team. My lab, though, is more focused on research. So we study the cardiovascular system and do this in patients and think about the clinical applications, but we also use rodent models. So we use mice a lot. 25 grams. Somebody have a guess what the resting heart rate is of a mouse? Yeah, Danny.
500 to 600 beats per minute?
Resting heart rate is 500 to 600 beats per minute. That's about right. So about 10 times a second, which is different than you and I, right? It's about 1 beat per second maybe, so much, much faster. 25 grams versus 50, 75, 100 kilograms for a human, right? So much smaller. But it's a 4-chamber heart. It has an aorta like this. And you can see there's renal arteries. It goes to the kidneys. It's very similar in a lot of ways from the cardiovascular system. So we use imaging to understand how vessels and the ventricle inside the heart deforms or changes, as well as the atria, and use something called tissue strain assessment, where we're looking at how much it's deforming through each beat. And then we can understand with that how it changes with disease. We look at compositional imaging. This is something called photoacoustic. So you're going to see a demonstration later today with ultrasound, and I'll be talking about that today, where you send out sound waves and listen for the reflection coming back. You can create images based on that time delay, how deep the structure is. You can also use photoacoustic imaging, where you can shine light into tissue. Imagine a flashlight, you turn on and off really quick, right? So that light will actually cause the molecules in the tissue to absorb that energy and expand a tiny amount. And that expansion can create an ultrasound wave to give you a photoacoustic signal. So you're using light to create sound. So that gives us a chance to look at oxygenation with photoacoustic imaging, deoxygenated, oxygenated hemoglobin. You can look at lipid, you can do things with nanoparticles like gold to get an understanding of what's inside the body as well. And then I won't talk a lot about this today, but we do and are interested in device development. Who's got a wearable watch on their wrist, right? It can tell you your heart rate, it can tell you your respiration rate, how many steps you've taken. This is a patch that we actually worked with a colleague on that goes right on top of the heart, epicardial patch, to measure ECG signal, the heart signal, not just over your entire body, but at specific locations as well. So I won't be getting into a ton of those details today, but we are interested in device development and work with some companies in this space as well. The big thing is that we always want to come back to the clinical need. We engineers, we can create fun tools that are really interesting, and then we talk to our clinical friends and they say, yeah, but we're not going to use that in the hospital. No patient is going to try to wear this device or use this technology. So we're always coming back to what does the patient need, how can we improve clinical care, and what's best for the patients in the long run. So with that, a quick outline. I'm going to talk a little bit about 4-dimensional ultrasound. So I know Megan's excited about this. I hope the rest of you are. 4D ultrasound is a nice way to describe gated volumetric ultrasound imaging. So instead of getting one slice, we get a volume, and then instead of just one time point, we get it throughout the cardiac cycle. So 4D, the fourth dimension there, is the time dimension. We'll talk about what we can do with that you can't get with standard approaches. We'll talk about myocardial infarctions. Do we know what another name for that is? MI? Yeah. Heart attack, exactly. So people going into the hospital for heart attack, chest pain, it's because there's a blockage in their coronary arteries called a myocardial infarction. We can do that in rodent models and then study disease progression as well. Pregnancy, your heart changes during pregnancy, both during pregnancy and then after, and it depends on if you develop hypertension or preeclampsia. It depends on if you're lactating after you deliver or not. We have a mouse model and collaborators where we're studying changes to the heart as well during pregnancy. And then also with patients with DMD, or Duchenne's muscular dystrophy, which is a congenital disorder that affects the dystrophin gene and muscle throughout the body, skeletal muscle, smooth muscle, and cardiac muscle. So patients that are having cardiac dysfunction or pathology based on this mutation. If there's time, I'll talk a little bit about aortic disease as well, mirroring aortic dissections. We do some simulation work with some great colleagues to talk about the vessel that comes off of the aorta as well. So, MI, and I'm going to prime this with some of the imaging work that we've talked about in the lab. So this is a B mode. This is what we call a parasternal long axis B mode ultrasound image. So that's a bunch of fancy phrases and terms to describe looking at the heart. This is the apex of the heart at the bottom. This is the aortic valve near the base of the heart. So the mouse's head is up to the left here, tail is to the right. I don't know if we see my mouse. And with this one view, we can estimate how is the heart functioning. So a common way to do that is to measure stroke volume, which is basically how big we see at the end diastole at its biggest point, and how small it is at peak systole. Subtract those two, and you get a stroke volume. Estimate how much the heart is pumping out each beat. If you divide that by how much you start with, you get an ejection fraction. So you would not expect, and you do not want, an ejection fraction of 100%. That means every drop of blood leaves your heart every beat. But you do want it above 50. So normal is about 50 to 70 in most patients. But if they have a heart attack, it can drop to 40 or 30 or down to 20 or even in the teens sometimes. And that's when you get into congestive heart failure. You really want to help those patients before it gets to that point. In this case, though, we're looking at a two-dimensional image, and we're estimating volumes based on geometric assumptions. So I'm highlighting here something called Simpson's rule. So volume is equal to area times length over 3, all these things. Basically, we're assuming this complex structure looks like a cylinder and a cone, right? We're making a geometric assumption. We can do something called M mode or motion mode ultrasound as well. We can track over time endo or inner, epi or outer boundaries. That M mode ultrasound allows us to look with this Tychol's approach and estimate volumes based on the spheroid assumption. But both of these and all these techniques, when we do this in the clinic, we assume this complex structure looks like a cylinder or a sphere or a spheroid, which we know is not actually true. So I'm a talented graduate student, so who's thinking about college once they're done with high school? Awesome. Who's thinking about graduate school once they're done with college? Awesome. So graduate school at FIU and BME, you can get a master's degree, you get a Ph.D., and there's also programs that allow you to get MD PhDs, so dual degrees, a medical doctorate and a research doctorate, and that's what Freddie did here. Freddie did the MSTP, Medical Science Training Program, MD PhD at IU School of Medicine for his medical degree and PhD in biomedical engineering at Purdue. He's actually now at Stanford doing a pediatric cardiology PSTP, Physician Science Training Program residency, intern year, residency, pediatric cardiologist in training, and he gets to see patients, right, kids and adults that have cardiac disease. But when he's in my lab, we took mice, and we did our standard short axis M mode and looked at how this movement of the endo and epicardial boundaries changed their, allowed us to assess cardiac function. We also put the mice in a really high field magnet, so 7T MRI, 7 Tesla magnetic resonance imaging, allowed us to look with a MRI approach how the ventricle changes throughout the cardiac cycle with a gated cine short axis technique. And you can see it looks really nice in this image in the middle, right? This is the left ventricle here, the papillary muscles that attach to one of your valves, the mitral valve, the septum separating the right and left side, and it looks pretty good. The problem is that these slices with MRI have to be about 1 millimeter thick in rodents, maybe 1 centimeter thick in patients, which means that if you look in these other planes, in your coronal or your sagittal plane, it looks chunky. And finding that exact order is really tricky. Plus, this is like a $1.5 million magnet. It took about an hour and a half to collect, to get the mice in the magnet, get them out. So it's not easy to work with. And what we then found, and we're trying to pioneer back in all the way, almost 10 years ago now, which is kind of crazy. This is so long ago, but the 4-dimensional ultrasound approach, where we can get very similar data, even better temporal and spatial resolution than what we can get with high-field MRI. So how do we do this, right? The big thing is we need to know where we are in the cardiac cycle. Who's heard of EKG before? Awesome, right? So this is what this green line is showing us from these mice below. So there's a P wave, which shows when your atria start to contract, a QRS complex, which is when your ventricles start to depolarize, and then a T wave, which is when they start to repolarize. We can track that, and we can then collect images throughout the entire cardiac cycle at different points. So these are different locations across the chest wall. And then afterwards, we can go back and what we call retrospectively gated, create a volume based on, in this case, the peak of the R wave. This is the R wave here, and we're going to reconstruct a volume that represents just this one time point. We can go a little later in the cycle and create another volume, a little later for another volume, a little later for another volume, until you have a 4-dimensional ultrasound data set, gated, respiratory and cardiac gated, volumetric ultrasound, or 4D ultrasound. Arvind Supriyatna is a Ph.D. graduate from the lab, is now at Brown doing a postdoc with Korean Colomb on some of the patchwork there. And he did all his work in this mouse models, where we can acquire data that gives us both EKG and respiration. Because if the mouse is breathing in, you get respiratory artifact. And this is what the system looks like. This is actually an older version of the system that you have here at FIU and the one that we now have in the lab. But these mice are so small and the transducer is so hard to hold that we don't actually just grab onto it like you will for some of our clinical systems. We clamp it to a rail mount system that's on a table that's stationary in the lab, and then attach that to a linear step motor. So this black box in the middle here can allow the transducer, move the transducer across the chest wall in very prescribed increments, down to 30 micron step size. So really, really small, and allows you to know exactly where you are imaging and where you are in the cardiac cycle. So the big thing here is the gating, and it allows us to get full volumetric coverage. So people in the ultrasound field are used to seeing images in the short axis and long axis, just depending on where you turn the probe. What you don't always see is this coronal view. So this is as if you slice the mouse, across the front. You can see a couple artifacts here, the sternum, the rib cage artifacts. This is the left ventricle here. And then in this 4D view, you can cut obliquely, any plane that you want. You can make an image and a movie so you can see what you want in any direction, which also helps with consistency, because ultrasound can be a little finicky sometimes if you don't collect at the right angle. What we find then is, right, it's not a sphere, it's not a cylinder, it's not some perfect geometric shape. It is a complex structure. This endo and epicardial borders are changing constantly. The septum moves differently than the free wall, the anterior wall moves differently than the posterior wall. So all those assumptions where we're using Tycholt and Simpson's approach are probably off, and this is where the 4D ultrasound can really be helpful. I also wanted to show a few example images of what else we can look at, because I know there's some heart valve work happening here in Miami. This is the murine aortic valve. So if you show this real quick, there's 3 leaflets. There's the left, right, and non-coronary cusp of the aortic valve. Correct me if I'm wrong, Josh, right? I think that's right. Some people have 2 leaflets, they have a bicuspid valve, but this is about 1 millimeter in diameter, and it is beating 600 times a minute. And so to be able to get a 4D data set allows us to look at these 100 to 200 micron thickness leaflets moving, right, and opening and closing, opens up possibilities to study valvular disease as well. So we did a little bit with Mike Sachs at UT Austin and Joy Lincoln and in Wisconsin, and we're still exploring this. So this might be a way that we can collaborate together in the future. But we can measure and look at the tricuspid valve, which separates the right atrium from the right ventricle, mitral, which is the left atrium from the left ventricle, look at the left atrium and left ventricle, the ascending aorta, the coronary arteries, and then actually quantify some of this. So this is on the left here, the valve when it's open. This is the leaflets when they get closed. This is the opening orifice. You can try to estimate in both areas and thickness measurements, all these different parameters of the valve, and see how that changes with disease or with a surgical approach where you actually cause damage to the valve itself. So I won't talk more about that, but we'd love to chat more for those that are interested in this later. So back to heart attacks, right? What people often think about is that you eat so many cheeseburgers, eventually the lipids get full of your coronary arteries and completely close off your coronary vessels, your arteries in your heart. And that's kind of true, but also not. And the reason you have a heart attack at a moment's notice is because the fibrous cap over a lipid-rich plaque will break open. And just like as if you got a cut on the outside of your skin, that exposure to what's underneath that fibrous cap causes a clot. And it's actually the clot that causes this blockage in flow and myocardial infarction to occur instantaneously. And so what we're really interested in understanding is, one, is a plaque vulnerable? And two, what happens once a heart attack is formed? Because most of the time, 50% of the time, the first symptom of a heart attack is the heart attack itself, right? Most people don't know they're at risk for a heart attack before they develop it. And if you have a heart attack, some patients will have a small enough heart attack where fibroblasts will move into the region. They'll adequately heal. It'll be a small region of scar tissue, but it's preserved the geometry, and patients can live for decades after a heart attack and myocardial infarction. In another group of patients, though, there's a different remodeling pattern. So a low number of fibroblasts move in, and there's inadequate healing. And then there's this process of remodeling called dilation that leads to congestive heart failure. So inadequate healing leads to severe expansion of the heart. Really sick hearts get really big, and they don't contract very efficiently. So about 20%, 1 in 5 patients that have a heart attack are going to develop congestive heart failure within 5 years. And the problem from a lot of clinicians is that they don't know ahead of time which path the patient is going to take. And if they knew somebody who was at risk for developing congestive heart failure early on, they might treat them differently, right? More aggressive with medication, think about behavioral therapies in a different way, different approaches that you'd want to know if somebody was at risk for heart failure or not. So instead of working purely with patients and trying to get data from people that have a whole different, genetic backgrounds and histories and severities, we use a rodent model. So this is what we call permanent ligation of myocardial infarction. So the students in my group become trained mouse surgeons. They can put a tube into the lungs of a 25-gram animal. They will then do a small thoracotomy, which is an incision between the rib cages and between the ribs and the ribs, and expand and open up the heart surface, the epicardial surface here. So if you look very closely here, there's a little thin red line. That's the left coronary artery in a mouse. And in a healthy heart, it looks like this. And in an infarcted heart, once it's actually been damaged, you can see this region down below. So it's thinner, it's not moving as well, it's akinetic, and it's going to have a lower ejection fraction. And the way we do this is place a suture underneath the coronary and tie it off. You can either do that permanently, or you can do it for a short amount of time and then reperfuse. So ischemia, reperfusion. There's been studies back all the way into the early 2000s that showed that the infarct size is dependent on how long you tie after coronary. So in this case, 30 minutes, 1 hour, or 24 hours, at that point it's basically fully chronic or permanent ligation. You get a much bigger heart, which is one of the reasons if somebody comes into the emergency department with chest pain, they are thinking maybe this is a heart attack and want to get that diagnosed quickly and opened up, because if they can do it within an hour or two, the patient does much better than if they have to wait 6 hours or 24 hours before that blockage is cleared. So what Arvid did in this study was took 15 animals, 15 mice, and in some of the mice, he put a suture underneath the coronary, tied it off permanently, and then created a permanent heart attack or infarction. Another 5, he put the suture around, tied it off for 30 minutes, and then released it or reperfused. And another 5, we did the exact same thing, but didn't tie it off at all. So we called it a sham control, where no flow is reduced to the downstream tissue. And we could get a whole bunch of different data from these animals. So 40 ultrasounds, we can get Doppler, which is a way to look at blood flow. Who's watched the weather report, you see like fronts coming in and going away. The same type of thing. They're looking at Doppler shifts of those thunderstorms rolling into the Miami coast, right? Same thing here. It's the blood flow coming towards or away from the transducer gives us an ability to look at flow. And then we can harvest the tissue at the end. So after 28 days, we manually euthanize the animals, pull out the tissue, and then collect it for histology. We can look to see what happens from a tissue perspective. So he did this at a lot of time points. I'm only showing days 1, 3, 7, and 28 here. But in that sham group, that first group, cardiac function looked pretty normal. You were seeing contraction of the ventricle at the apex like you would expect normally. In the ischemia reperfusion group, where we did a little bit of damage, right, you see some changes though, right? A thinning out and a region where it's not moving quite as much. And then in the permanent ligation group, the most severe one, you can see this bottom right image, it's changed substantially, right? So that ventricle's gotten bigger, it's thinned down, and it's not moving nearly as much. The ejection fraction in this mouse is below 20%, and would not expect it to live much longer. Be a patient really sick with heart failure. So there's things that happen, and we know this, it's been published in the literature, right? The ventricle gets bigger over time with a heart attack. You see that here. This is exactly what happens in patients. And diastole and peak systole, this increases. The ischemia reperfusion group also increases, but not quite as large. So significant LV dilation in the permanent ligation group. The ejection fraction, like I was talking about before, how much blood is moving out for each beat. You can see a slight drop in the ischemia reperfusion group, but a much bigger drop in the permanent ligation. That's something that we'd also expect. E to A wave ratio, I won't get into those details, but it's basically how well the heart is filling, and that changes as well. So both permanent ligation and ischemia reperfusion exhibit systolic dysfunction, but filling or diastolic dysfunction is really only present in this permanent ligation group. These are all generic and general parameters that match what the literature shows. We wanted to go beyond that. We had this 40 data that we were really interested in. So this is Guy Jenin, he's a professor at Washington University in St. Louis, mechanical engineering, and Steve Thermopoulos, who's a professor of orthopedics at Columbia University in New York. And they, in their groups, helped put together a strain analysis workflow. So a technique called direct deformation estimation. So I won't get too technical here, but I want you to think about from one time point to the next, there's going to be a small amount of change. And you can actually look at the speckle patterns in the heart like you would the stars in the sky. There's a slight movement from one time point to the next. You can use that to estimate how much this is forming in a really high resolution, temporal resolution, and then back that out from the strain parameters. So the engineers in the group were estimating the deformation gradient tensor, that F, and calculating the Green-Legrand strain tensor in all directions in the full 3D strain tensor, which allows us to get these really pretty pictures. So we can look at top wall, anterior and posterior wall. We can look at a bullseye map to see from the apex out how the ventricle is deforming. And what we get is these surface maps, these strain maps on the endocardial surface that shows how this strain pattern changes. Sham group, nothing really differs. The ischemia reperfusion, we see only the apex, but in the permanent ligation, it's much bigger. The ventricle is enlarged, and that region is akinetic. It's not moving as much. We compared this to what we get with histology, where you can see and identify the thinned out regions. The literature typically uses anything below 0.5 millimeter as considered infarcted. And so we can compare that to what we get with our strain maps. So these bullseye plots, you can imagine you're down at the foot of the patient, and you're looking up towards their head. And the apex of the heart, the very bottom, is in the middle of this bullseye plot. We then unwrap it, and so you don't have to look around the sides. It basically comes out. The base or the outside of the heart is on the outside. So it's a bullseye map with the apex in the middle and the base in the outsides. And you can then use this approach where you're trying to identify how big this infarct is based on where we're seeing low regions of strain. And so the strain estimated is in black here, the thin walls and the white dotted, we see it matches fairly well in that permanent ligation group, although a little bit bigger, we include some of that border zone as well. In the ischemia reperfusion, it doesn't thin out enough to meet the criteria for less than 0.5 millimeter, but we do still see regions that are akinetic. And the bigger thing is the timing, right? When do we start to see changes? It takes a patient sometimes 6 months, 12 months to really start to develop congestive heart failure and show that they're moving down in their cardiac function, whereas the strain patterns change more quickly. And so what we notice in these first days, right, in this 1, 2, and 3 days, we're already starting to see big changes in strain that you do not get when you're looking at just the thin wall estimate, this light blue line. So the idea here is that instead of looking at how much the wall is thin 6 months down the road, look at the dynamics of the heart early on. Figure out where there's reduced strain, where there's reduced deformation or contraction, and use that to predict eventual extent of wall thinning and how severe the heart is. Okay. I'm going to move on quickly just for the interest of time, and I am going to leave time for questions, so I do want to make sure at the end we've got a chance to talk. But I do want to talk a little bit about pregnancy. When I was trained, we learned a lot about heart attacks and coronary artery disease and aneurysms, and we didn't really talk about pregnancy because why would we be interested in women's health, right? And over the years, that's really apparent how little the field has thought about women's health and disparities in relation to not just heart attacks, but what happens in pregnancy and the amount of times that there's maternal issues, not just during pregnancy, but in that postpartum period as well. It's really shocking to hear about. So we worked with a group at the University of Minnesota. Kyoko Yoshida and Molly Kaiser are at the university there in the Twin Cities. And we looked at how hypertension is going to affect remodeling in the same mouse model. So it's a leading cause of death worldwide. There's both volume and pressure overload issues, right? If you have more blood coming back to the heart, it can dilate, or if it's having to push against a harder amount of pressure or a large amount of pressure, you can have problems. And so we want to understand the interplay between these two. In volume overload, when you get more blood coming back, you get increased preload and an eccentric hypertrophy, right? Where the ventricle actually dilates and gets bigger. Where pressure overload, you have increased afterload, which is the amount of pressure the heart is pumping against. So you get concentric hypertrophy where the walls thicken and a decreased stroke volume. And so you can have one or the other or both, and we want to see how these interplay. Both of these can lead to decompensated heart failure and death eventually. Chronic hypertension, have you know anybody with high blood pressure? Treatments for high blood pressure is the most common therapeutic medical prescription in the world today, right? There are tons of people with hypertension, especially uncontrolled hypertension, and blood pressure can only be controlled so much with medication, but especially during pregnancy, it puts both mom and baby at risk. So fetal growth restrictions can cause problems. These moms that have chronic hypertension often have preterm birth, and there's increased maternal and perinatal morbidity. So there's work in this rodent space. This is actually from a rat model, but you can see this is the heart tissue that we've taken out and run histology, so microscopy images of. Sham looks fairly normal with only a little bit of red or the collagen. The pregnancy group, it looks maybe a little bit bigger and thicker muscles, but no collagen. You give a rat hypertension, high blood pressure, it gets collagen rich, so it gets stiffer and it doesn't contract as well. The interesting thing is if you give a rat that has high blood pressure and they're also pregnant, it mitigates that effect. So it comes down a little bit. You don't see that same change. And so we're trying to figure out why is there not the same disease in pregnant rats as in the non-pregnant rats that have hypertension. So with that, we're looking at this interplay between pressure and volume overload in pregnancy where it's really an unexplored case. And the thing with our group, we're always thinking about function, the biomechanics with those strain maps, and geometry as well. The objective here was to characterize the effects of combined pressure and volume overload on LV remodeling. And the hypothesis is that the pregnancy is going to blunt some of the effects of this chronic hypertension associated with cardiac remodeling. In the study, we did 5 animals that had chronic hypertension, and then they were pregnant. Another group that had chronic hypertension and did not get pregnant, and another group that got pregnant but did not have chronic hypertension. So we're always thinking about controls, right? How we're comparing these different groups with only one variable changing. Again, a lot of imaging. So people, right, it's a 9-month before babies arrive, right? 40 weeks in mice, it's 21 days. 28-day menstrual cycle in women, it's a 4-day estrus cycle in rodents. So we can study pregnancy quickly this way, and we can get a lot of pups and look at pregnancies again and again. These are the different groups and how we did the schematic here, showing when the imaging happened versus when we looked at when they got pregnant. We measured blood pressure. Who's gone into the drugstore and put their arm in the tube that then inflates and deflates and gives you systolic and diastolic pressures? Same thing with our rodents. They go in this little tube, and then their tail sticks out. And we put a little sensor on the back. It inflates and deflates, and we can measure systolic and diastolic pressures. So people, right, normal is about 120/80, maybe a little less if you're healthy. Does anybody have an idea what the blood pressure in a mouse is? Yes. Students? Yeah? No? Yeah, tell me. Yell it out. Close. 120/80. It's the same as us, right? So even though the heart rate is much faster, the cardiac output is much lower, the body mass is lower, it's 120/80. Same type of systolic and diastolic pressures. We can image. This is what baby mice look like in utero. So instead of 20 weeks and 30 weeks of gestation, we have embryonic day 5.5, 6.5. We say 0.5 because usually they get pregnant at night. So day 5, day 6, day 7, they keep growing. And with that, at day 10, you start to see what looks like a fetus. We can image them, right? We can look at the heart with this 2D approach. We can get ejection fraction, stroke volume, cardiac output. We can look at short axis approaches, scans to get the 4D technique, to get volume, mass, wall thickness, and contractility. And we found a few things, right? Ejection fraction does change throughout pregnancy. In the pregnancy control group, these triangles, it goes down slightly as the fetuses get larger, and they go up. Unlike most humans, right, we have litter sizes between, let's say, 4 pups all the way up to 12, right? So mom can have 12 mouse pups at a time. We have seen that in the hypertensive control group, right, the ejection fraction, this one, it stays and even drops slightly, whereas in the hypertension plus pregnancy, it more follows what we see in the pregnancy group than in the hypertensive group. The stroke volume also changes, right? You expect this to go up during pregnancy, which is what you see in the triangular group, it goes up, right? And we also find that as well in the hypertensive plus pregnancy group. There's more blood needed for the pups to grow. So decrease in stroke volume and due to hypertension are overcome during pregnancy. The cardiac output also changes slightly. So cardiac output is stroke volume times heart rate. Decrease in cardiac output due to hypertension that can be overcome during pregnancy as well. So basically all these parameters are mitigated by pregnancy that you would expect the changes due to hypertension. So in general, pregnancy you're going to maybe be protected, cardiac remodeling, especially in the setting of hypertension. So that's the general ones, but now we're getting into, and I'm hoping the student can get the paper out soon, a more robust 4D analysis. So these are what we call strain plots from the base or the top of the heart to the apex or the bottom across time. And you can see that the pregnancy control group looks normal in this nice, healthy contraction. There's a lot of yellow here showing large amounts of strain. Whereas the control group, the hypertensive control group decreases quite a bit. So we don't see that same strain pattern. But this hypertensive plus pregnancy group more closely mimics that pregnancy group than the other way around. So gross morphology, right, we'd expect heart mass to get increased as well. There are some differences between these, right? Increases in heart mass, stroke volume, and cardiac output due to hypertension are reduced in pregnancy. And we're putting all this together, right, to understand how this change in volume and pressure overload affects the heart. We're assessing cardiac function geometry, physiology, mechanics, and thinking more about how pregnancy can blunt cardiac remodeling. Not in that we want to get hypertensive patients pregnant as a treatment, but if we can understand the underlying mechanisms, you can figure out ways to treat patients that are hypertensive, as well as make sure that pregnant patients aren't going to undergo cardiac disease during pregnancy and in that postpartum period as well. Okay, I think I've got time for maybe one more cool project. So this is where we started working with pediatric cardiology. So at IU, this is Riley Children's Hospital in Indianapolis. Larry Markham is the division chief there. He's actually about to move to Vanderbilt, so he'll be there in April as division chief down there. And Connor Earl did the same MD Ph.D. program with our group as well. We put out 2 papers. I'm sure you've all read these already. This is in the Journal of Cardiac and Vascular Magnetic Resonance Imaging, talking about renal strain adaptation. So kids with Duchenne's muscular dystrophy, Becker's muscular dystrophy, or other types of dystrophin mutations, right? They have issues walking eventually. They can have issues with the diaphragm and breathing, right? Weakened diaphragm, muscle degeneration. Oftentimes they do end up in a wheelchair. But what kills more than any patients is heart disease. And so this Gower sign, where they need help standing up and eventually they need help getting around, it's really horrible to see, but we've got ways to treat that. And what kills more patients than not nowadays is cardiomyopathy, changes in the heart. And so what normally occurs with healthy myocardium and a little bit of extracellular matrix is the change, right? There's much more fibrosis. The ventricle becomes stiffer, it becomes enlarged, and you get gadolinium enhancement in your MRI scans, and by that point, it's almost too late. Ejection fractions drops into the teens, and these 12, 16, 18-year-old, usually young boys, because it's an X-linked recessive condition, they'll die, they'll pass away, right? So it's the number one cause of death, and we don't understand progression and when rapid progression occurs. So we took our same approach, and instead of using ultrasound in 25-gram mice, we looked at patients. And these were from Indianapolis, from Nashville, from Columbus, Ohio, from DC, Seattle, Boston. A whole consortium of patients in pediatric hospitals around the country gave us cine-stacked cardiac MRI. And so while it is thicker, we were able to do a similar strain mapping pattern. Look at the base and apex, look at all the way around the circumference, and then calculate the circumferential, longitudinal, radial strains, as even a surface area strain parameter as well, to look and see if we can identify cardiac function in these patients better than just looking at ejection fraction. So during systole, as the heart contracts, is this blue line, followed by early diastole, and this initial relaxation, and then late diastole. And we can look at strain rates as well, these changes over time in these different directions, circumferential, longitudinal, radial, area strains, plot them in different directions, and look at how fast they're relaxing or contracting. What typically happens in these patients, right, is that everybody's at stage A. They're at risk for heart failure, but they have a normal ejection fraction above 55% and no late gadolinium enhancement. Basically, it's an MRI technique with a contrast to see if there's fibrosis there. So without that and a good ejection fraction, you're stage A. You're in the clear, you're pretty good. Eventually, though, patients move on to stage B, where your ejection fraction is still good, but you'll develop late gadolinium enhancements. And then fairly soon thereafter, they move on to stage D with a reduced ejection fraction, and then finally C and then D with advanced heart failure with ejection fraction less than 40. And this is where typically you're in your early 20s, but you might only have then 6 or 12 months more to live. And so understanding this progression, when this happens and how quickly the decrease occurs, would really help the clinicians we talk to with patient treatment. So we looked at a couple things. We looked at a group with 43 DMD patients and 25 controls and found not only is there a small change in ejection fraction, but we see these regional strain patterns as well. We looked at and see if we could identify if our approach with surface area strain was able to better distinguish these parameters, and sure enough, it can when you compare to the regional, mid, apical, or global strains. We then looked at fibrotic dysfunction, and so this is a chance for us to look at these same bullseye maps again. We looked at those with late gadolinium enhancement, in this case MDE here. There's a significant difference between those that develop this fibrosis versus those that don't in surface area strain at the base, and correlates then, I guess, with this amount of fibrosis. And then we looked at another subset of patients at an initial visit, 1 year later, and 2 years later. So you can see the numbers, 40 to start with, 38 and 36. The reason we don't have 40 at year 2 is because 4 of those patients passed away. Here we can see ejection fraction changes as well, but looking at this, right, you go from initial stage A, some stay there, but a lot drop down to stage B, some in stage B drop to stage C. You can see this called a Sinky diagram, how patient changes over time. And this is one example. It's just one patient, and the publications go into more details. But if you just look at ejection fraction, anything above 55 is normal. So this patient initially had an ejection fraction of 62, and then 1 year later 60, and then 1 year later 58. And we would say normal, healthy, no problem, right? But they develop gadolinium enhancement, which means there's fibrosis, and their strain pattern changed substantially. So here you can see the yellow down here that goes away at year 1, and sure enough, that's where we start to see this delayed myocardial enhancement or gadolinium collection between years 1 and 2. Maps of these bullseye plots as well, right? Showing the same approach that you can see these large posterior strain and apical strain that goes away at 1 year and 2 years. Again, suggesting that strain might be a better approach than just an ejection fraction metric. So with that, we looked at and further identified in this group they were considered either stage A or B, fast and slow progressors. And that's the big thing that we want to identify for patient, for our clinicians, right? Who in your initial group that looks normal is going to progress quickly to heart failure, and who's going to stay normal? Because in that fast progressing group, in this case, group 2 here in the yellow, we want to identify if we can distinguish those. So just ejection fraction, this is getting into statistics, but basically no difference. They look exactly the same if you look at global functions. But if you look at strain, you start to see differences. And we can actually pull out changes, right? There's regional 40 strain differences that we can identify that helps identify which patient is going to be in this slow progressing group, which you don't need to treat, and which fell into this 9 patient group that had this fast progressing group that move on to stages B and C and D. So this is still a work in progress. We've got a lot of efforts here. This is the group of hospitals that initially reported this consortium, and we've been adding more over time. Who's heard of artificial intelligence? Awesome. So right now the students go and draw a bunch of circles, and it's really boring and it takes forever. So we want to speed that up and not be so boring for the students and the cardiologists and the fellows. And so the goal is, right, you can feed in this data to a pipeline, use UNets and convolutional neural networks, and now instead of having to do it manually, you can spit out the segmentation without going in for it. And we also want to see if we can understand some of the more better treatment strategies. So you can use the same ones they've identified for adults, but it's really not ideal for some of these kids. And so corticosteroids, angiotensin converting or ACE inhibitors, angiotensin receptor blockers, beta blockers, all these different things, right? They're designed for adult patients. In some of these kids, though, we want to think about other newer approaches. So there's a new type of drug out there called an SGLT2 inhibitor that just came on the market for other conditions, and we're trying it out now in rodents. And what we can do now is study mice to help us understand what's happening in patients. So this is a wild type mouse, normal function. This is what a D2 MBX mouse is. We kept the actual imaging parameters the same here. So the first thing that we notice is this nice signal contrast, although it's not showing the video quite as well as what we see on the scanner, it reduces the quality quite a bit. All this signal up top is because there's fibrosis in that skeletal muscle, so the image quality reduces quite a bit. You can also give these mice something called isoproterenol, which is what we call liquid exercise. So instead of making them go run on the treadmill or go run around the track, we inject them with a drug that increases the heart rate and contractility. And so you can see here, it's a much more forceful contraction that then speeds up this disease process. So instead of waiting decades for patients or years for animals, we can do a study that takes just a few weeks and speed this up. And so in this case, we are showing what happens when you treat mice with SGLT2. This drop in injection fraction that you typically see in these rodents that have this mutation is preserved all the way out to 12 weeks of age, and then it goes down. And so our hope is that if you can do this in these early stages, you can keep patients at this preserved ejection fraction without this drop, and identify early on when that's going to happen. So a quick summary here: standard imaging metrics cannot differentiate progression of patients with subclinical cardiomyopathy. The 40 strain patterns can separate between slow and fast progression, and the regional and temporal strain of cardiac MR strongly differentiates this 5-year survival in these EMD patients. I am actually going to skip my aortic dissection. If you want to hear about aortic work, let me know later. I'm happy to go through it. I'll show you some pretty pictures, including what you can do with MRI in the mice, as well as 40 ultrasound. This is the kidneys and what this looks like in the abdominal aorta. You can get 40 data. It looks like it's showing what happens once it's pulsating away. But I am going to skip right ahead to SEM, scanning electron microscopy images, which are also a fun way to look at extracellular matrix. So we can talk more about that later too. But cells are then encompassed and can get contracted inside of clots. And this is a fun way for us to look at what's happening inside of changes in the vessel wall, either intramural or luminal dissections and aneurysms. But with that, some takeaway messages. So the only thing you listen to is this one slide. Please remember 40 and volumetric ultrasound or MRI imaging. We can use this to assess cardiovascular kinematics. We can integrate imaging and strain mapping that allows us to look at remodeling quantification, predicting progression of disease, and impacting novel therapies. We think about our studies not in the group sense, but in the animal and patient-specific analysis. We want to make a lot of measurements from the same animal and the same patient so that we can understand what's normal for that individual person or individual animal, so that we can monitor disease progression. We're not comparing that mouse to the group or that patient to the larger group. We're comparing individually what's happening to that person over time. Always thinking about early identification and risk stratification, really to think about ways to improve prognosis, treatment, and patient outcomes. With that, I want to thank the group again, wonderful PhD students that are fantastic to work with. Our collaborators at Purdue, externally, some in France, in Louisiana, in Texas, in St. Louis, in New Haven, but nobody here in Miami yet. So I got to add Josh to this. And so Josh, thank you. This is from a couple of years ago. But thank you for
Time for questions. Fred, amazing talk. Almost as good as mine yesterday.
Yeah, I think shoes.
So, I have a question for you, and that question is, how long would it take for this to be implemented and used in the clinic, or how long will it take for this, science to end up in textbooks for MDs or high school students to learn about cardiac function?
Yeah. So the broader question about adoption, if everybody heard that right, just how quickly can we get this specific technique in, and how quickly can some of the parameters help with medical adoption in general? So it's interesting, right? There are times where there's an advancement, but yet the clinical community doesn't always jump on it. And that can be because of reinforcements, because of cardiology and radiology not always seeing eye to eye. It can be because of key opinion leaders making statements or having their own opinions. So, getting somebody to adopt means you have to show value and show improvements, not just in the patient care, but sometimes in the cost and what happens in the long run. So that's everything from getting through FDA and regulatory to getting reimbursement codes to then getting licensing or a company to actually sell some of these products. So that is down the road for us. We're not ready to go and say the same technique can be used in patients next week. That said, right, some of the strain mapping is being used in patient data already, and specifically with the 4D ultrasound, right, what we do with a thoracic imaging approach in rodents where the transducer goes across the entire chest is different than what happens in the clinic. There are now 2D arrays where you can get volumetric data. Transesophageal, you can get transcutaneous across the skin volumes as well. The problem there is that these cardiac windows between the ribs in patients are smaller. So really the right approach there, we're thinking is multiple volumetric acquisitions that you then stitch together retrospectively, assuming that the cardiac cycle is fairly periodic. The clinicians that we've talked to are interested in that. We have not made a ton of progress because they're used to just the 2D simple 5-second parasternal long axis. So I think the question for us in our lab is, what's the value? How do we show that this is improvement over what we typically do? And part of that can be, well, instead of sending a patient to cardiac CT that's going to have ionizing radiation, or MR that's going to require large magnet with helium, here's this ultrasound approach that gives you that same information volumetrically that is going to be cheaper and faster. So still a work in progress. Great question. Sure. So the question is, what about other organs or diseases? Yeah, absolutely. So the 4D ultrasound looks at changes in shape and deformation, which is ideal for the cardiovascular system where it's very pulsatile. That said, we get changes in the gut, right, as it's moving food downstream. We get changes in the diaphragm as you breathe in and out. In the brain, you get blood flow as well. Your brain shouldn't be contracting and expanding at quite the same levels, but you can use volumetric ultrasound there for sure, and you can understand complex flow patterns with some of the newer, the F2 has this color Doppler plus 4D ultrasound, so you're looking at the whole volume plus then blood flow through some of these more intricate arteries and veins, which in the brain is really important if you're looking at malformations or cerebral aneurysms. In the brain, you have to kind of take care of the skull and think about how that affects things. So in the humans, it's often through your lobes and the openings on the side, your temporal lobes. And in mice, if you're early on, you can actually get through the skull before it gets really thick, but it's not as always easy.
So, that was really interesting talk. The strain mapping I was really interested in. The aortic valve performs a lot more than the actual heart does. Do you think you could do the strain mapping on the valve like that? Or do you think that would be a lot more?
Yeah, I mean, maybe. We should talk more, because it's, I mean, looking at the thickness, so, I mean, 120 micron leaflet thickness. Our strain approach allows us to do a few things, but you're often in either with the DD averaging across the voxel, which you might get some partial voluming effects, or if you looked at just the surface area strain, you really want good resolution of the entire leaflet, and we're often getting just the coaptation points. So we're estimating it based off of that. The group that we've been working with, right, in Texas and in Columbus uses micro CT ex vivo. So they pull a heart valve out, they load it at different pressures and get super high resolution data, which we then compare to in vivo. That probably would be a better approach if you wanted to get a really in-depth study of valve deformation. But once you pull it out, right, everything changes too, right? So, good question.
Great talk. My question is, in terms of most diagnostic approaches, the skepticism is lead time bias. Do you think that specifically, say, with BME, that could creep in, and because there's no good treatment modalities, even though you're detecting this very early on, the eventual outcome and therefore the eventual adoption of the diagnostic method might never happen?
Yeah, so we're thinking about predicting disease progression. It's always tricky because you never can say with any certainty what will happen to a patient in 6 months. So that's why all these studies are retrospective to begin with, and then prospective with very precise control groups. I would say we would never tell a clinician to forget ejection fraction in your standard approaches and just use this. We would say this is an additional tool, right? This is use what you've done and your training and what's already in the clinic. And now also think about a strain parameter map or some other metric that we're helping to identify, your surface area strain, that will give you additional information that might be only a small subset of patients, but those with healthy ejection fractions and what normal wall thickness, but have this really abnormal strain pattern or something that looks off, you may now want to have them come in 3 months instead of 6 months, or start therapy earlier than you would expect. I mean, that said, it's not always easy to predict what's going to happen, and getting that buy-in takes clinicians to understand what you're telling them and know that it's just one piece of the puzzle. It's never, you know, the end-all be-all or perfect metric.
One more question.
The innovation is in the instrumentation of transducer and signal collection, or how do you only enabling?
Yeah, so the company that we work with, you know, we decided when we started the lab that we could build our own ultrasound system and a transducer and all these different things. It would take us probably 20 years because it's a really difficult problem. This transducer has 256 linear elements, piezoelectric crystals put together. The amount of engineering that went in just the head of this transducer represents decades of engineering advancement. So we decided, well, let's just use what's commercially available, what's already available for the preclinical space here or in the clinic that we talk to with our patients. And once the data is collected, then we'll work on doing things offline. So the Vivo Lab software toolkit that Visual Sonic sells is great, but it doesn't do everything. And so a lot of the analysis we do is offline. We take it to DICOM or other formats, run into MATLAB. The graphical user interface we use is mostly MATLAB. We're now moving to Python, getting executables, sharing it with folks that even the residents and fellows that are working with their data, right? They don't want to use their own toolkits either that are limited. There's Metis and Circle and other approaches to people that are creating commercially available software, but ours can give them a lot more information. So we always love working with the mechatronics folks that can build their own actual devices because it really is a nice complementary expertise to what we've done. But everything here is you can purchase from a company.
Let's thank Dr. Goergen again. All right, so we'll move on to the next part of our program, and our folks from the Star Center want to come up and start getting ready. I'll fill time since I should have actually started with this is a really hard event to put together, and I want to make sure that we don't forget to thank while people are in here. So first and foremost, our BME department has been incredibly understaffed. It's been a heroic effort by Claudia Estrada and Michaela. It looks like they're doing a job. Putting everything together and how amazing this looks in here, so thanks to them. I want to thank the folks at the Star Center. Ricky had reached out to me and wanted to put all this together, demonstrations. It's fantastic work you're going to see, so thank you to the Star Center for being involved in this. For the high school program, everyone involved in CD Sec, so hopefully don't forget anybody, but Bailey, Mays, Thelma, Dr. Demonte. So thank you for getting the high school students here in the high school outreach program. And then finally, our funding from the Florida Heart Research Foundation, FIU Office of Research and Technology Development, and the FIU Biomedical Engineering Coulter Endowment for paying for all of this. So with that, we will move on to the next part of our program. I'm super excited about this. And for those of you who are either now studying engineering or may want to go into engineering in the future, I think this is going to be an incredible demonstration of what engineers can do, maybe even behind the scenes, to help train our future clinical practitioners.